네, 안녕하세요. 잠시 안내 말씀 드리도록 하겠습니다. 저희 9시 30분부터 저희 한국보건의료연구원 2022년 네카 그레이드 센터 국제 세미나를 시작할 예정이었는데 조금 장내 정리와 이제 도착하실 분들을 조금 기다리기 위해서 3분 정도 시간을 더 갖도록 하겠습니다.
We, we would like to let you know that we will be starting our seminar at 9:33 due to our preparation. If we would like to invite you at 9:33 once again.
네, 안녕하세요. 현장에 참석하신 여러분, 그리고
Thank you everyone for participating in this seminar, online and offline. Thank you for joining us, even with your busy schedule, on 2022 NECA Seminar. Today, I will be proceeding with the MC and the presentation for our NECA seminar. Grade methodology has been doing with the grade work group. It has been assigned as the grade working group in 2021. We will be starting our 2022 NECA International Seminar today. Today we will be starting with our Han Kwang-hyuk, President of NECA Korea. We have a recorded video proceeding. Good morning, everyone. Good morning, everyone. I am Han Kwang-hyop, the president of Neca Korea. I congratulate everyone for taking part on the first ever 2022 Neca Grade Center International. Unfortunately, I was not able to join you due to a business trip. But since it's such a significant event, I at least wanted to greet you through a video. First, thank you both online and offline Neca family and researchers for attending the seminar. For our seminar, it is a great honor to have with us, live online and as a speaker, Holger Schnumann, the co-chair of Grade Working Group. He is currently the most renowned specialist for the grade approach. I am also grateful to have Akiko Okumura from Mainz Tokyo Grade Center and Heath White from Melbourne Grade Center, the leader of COVID-19 guideline, for joining us online. For local speakers, we thank developers of clinical practice guideline professors Kim Soo-young, Jung Jae-young, Lee Young-kyung, Kim Yang-kyung for being with us at our workshop seminar as specialists of grade guideline despite your busy schedule. Thank you to all. Your seminar will shed a light. We Neca Korea for years has supported the research to develop a national health research and health technology. Since its inception, various efforts have been made to set the international standard for systematic health technology methods. The grade guideline has been actively introduced in systematic reviews and clinical practice guidelines, and currently, NECA's health technology evaluation projects and clinical practice guidelines have officially adopted the grade guideline methodology and are making progress in determining the level of evidence and difficulty. Since I took office as the president, our healthcare agency has formed a new team to efficiently spread the clinical practice guideline development method nationally and systematically participate in the designation development process. Through this, collaboration with a group of domestic experts was more effective, and there were visible results in a short period of time. While officially collaborating with the Korean Medical Association, we developed the COVID-19 living guideline, and it's been receiving good reviews from domestic officials. In addition, this year, Clinical Practice Guideline Handbook account draft was published to reflect the latest information. Based on our activities so far, we have succeeded in maintaining a grade center for the first time as National Health Research Agency. It is said that the leader must have a map and a ruler. If a map is needed to find the right way, there must be someone to check the work. And I think grade center is that to confirm the standard and basis of the ruler. Today's seminars is to inform the achievements and activities of the grade center, ensure how to apply it to the grade systematic process to achieve our vision as a national health technology assessment agency. We would like to proceed to grade guideline methodology and strategically reflect it in the future research projects. Finally, I would like to thank all the people who had made this seminar happen. I would especially like to thank Grade Center researcher Chen Myung for supervising everything for this seminar. We, NECA Korea, as a leading team, will not hesitate to develop our research even further. Thank you very much. We would like to inform you that the translation is 5 and 6. 5 is going to be Korean and 6 will be in English. I would like to introduce everyone who's been internationally so that our videos are in smooth process. They have given us their video and they will be joining us live online. We have asked them for a previous video to be recorded. We have Canada McMaster University Holger Schneemann. Before, he was so busy that he wasn't able to join us. And we have his wife for the Australia COVID-19 guideline evidence leader. And we have Akiko Komura from Grand Center. And locally, we also have presenters live, but we will be introducing them a bit later. We have Choi Ji-yeon as the researcher and Chung Jae-young professor. We will be starting our first procedure. We will having a Korean and English translator both. We have Holger Schneemann as introduced. I wasn't able to think that I will be able to introduce this person live or not. We have Holger Schneemann, and the introduction will be short. He is the Great Working Group co-chair, and he has WHO Collaboration Center for Infectious Disease. He is the director of Cocaine Canada, and he is the father of GRADE guideline. The presentation will go through with the video, and we have a live Q&A question time. We would like to ask Newman for his presentation.
Hello everybody, it's a great pleasure for me to be here today virtually and talk about bridging decision making in health, the theory of everything. I of course would have liked to be there in person, but unfortunately due to timing that was not possible. Nevertheless, I hope that you will enjoy this presentation and obviously the meeting or conference. Here are my disclosures. I do not have any direct financial conflicts. I'm co-chair of the GRADE Working Group, and I have affiliations with a number of organizations that are shown here on the slide, including Cochrane Canada, or Cochrane in general, and the Guidelines International Network. For disclosure, I would like to mention that I have received payments from the WHO for workshops and research, and I would like to express my thanks to the Theory of Everything collaborators. You will see what the Theory of Everything is about. Today's talk is going to focus on the evidence ecosystem and how it relates to health decision making. I will present a framework for thinking and working together and provide 2 examples related to health outcomes. The work that I'm going to be presenting has been published earlier this year in April in the Lancet Public Health, and this is the publication that I'm referring to. The ecosystem of health decision making from fragmentation to synergy, and we call that the theory of everything in health. So the problem is that clinicians, the public, including patients, policymakers, payers, regulators, and the science communities influence or make decisions. They do this at various levels by using systematic reviews, health technology assessments, guideline recommendations, coverage decisions, the selection of essential medicines or diagnostics, quality improvement, and policy or evidence briefs, on top of regulation, obviously. The extent, however, to which different actors in health decision-making use structured processes and transparent criteria differs, and these processes are often poorly coordinated. There's a couple of examples. So Cochrane and the Guidelines International Network started quite a while ago trying to work together in terms of identifying priorities for reviews that then can be used in guidelines with mixed success. The Guidelines International Network is also working with the International Network of Agencies for Health Technology Assessment in its GENATA working group that I also co-chair. And that work focuses on bringing these different groups together. There has been a lot of work trying to bring groups together. This is an example that we published in The Lancet in 2009, a vision statement on guideline development for respiratory diseases. And there we worked with over 20 organizations, including the WHO, Health Technology Assessment organizations, in order to see if there would be a model that could bring together different health decision makers to develop guidelines. So Cochrane was involved in that. But these efforts have really not been fully productive. So the goal for this work, for our framework, is to lay out concepts of decision making and then create bridges between disciplines that actually go beyond the partnerships that are already somewhat established despite the lack of full successes in HTA guidelines and systematic reviews. I should also mention that there is other success stories, such as a story from Brazil where the Ministry of Health has bundled guideline development and health technology assessments through some qualitative work that revealed that these different segments in the ministry really should be working together, and I think there are some success stories. However, as background to this work, there has been a lot of work that we've been doing with the WHO country office in Estonia on guideline methods and capacity building and evidence-based decision making. An example for the type of problems that we've been facing was that there was a submission of an application of new oral anticoagulants, direct oral anticoagulants, or DOACs as they are also called, in the WHO essential medicine list, which was rejected. And at that time, there was no WHO guideline. The Estonian national guideline context provided a conditional recommendations for such DOACs in atrial fibrillation. And the recommendation was conditional because the costs were too high for a strong recommendation based on systematic reviews and the health technology assessment. That led to price negotiations, so coverage decisions involved, with the Estonian Health Insurance Fund. The manufacturer lowered the price, and it came to a strong recommendation. In addition, in 2019, the EML approved DOACs. So here you see some interplay of different actors that work together in the space of health decision making, and you see how one decision influences another. So under the aegis of the World Health Organization that included the WHO Euro office, the country office in Estonia, the Health Product Policy and Standard Office at headquarters in WHO, and the Estonian Health Insurance Fund, we started in 2019 to bring together representatives of different areas to discuss how the evidence that influences decisions and the actual decisions relate to each other. We looked at the factors that influence a decision or criteria, and we looked at the type of evidence that would be required and where it comes to play. Finally, we looked at who is making recommendations and decisions and in what contexts. It became very clear that the questions that are asked when making health decisions are very similar. So, for instance, the first question that everybody asks is, are the expected health benefits greater than the harms, or vice versa? And this integrates considerations about the priority and severity of the problem, the intervention effects, the values people place on the outcomes, as well as the certainty in the effects. The next question that is being asked is, what is the magnitude of the resource requirements and the associated cost related to the intervention or strategy? And is it actually cost effective? In addition, what is the impact of the intervention or strategy on equity, including societal implications and the environmental impact? Is the intervention or strategy acceptable to different stakeholders is another important criterion that includes ethical and other considerations. Finally, is the intervention or strategy feasible? This criterion includes health system, societal or social, legal, political, and other considerations. So as a starting point, we chose what is well established in GRADE, the evidence to decision frameworks. The evidence to decision framework include most of the criteria that I listed there, for which there was agreement that they would play an important role in decision making. For those of you less familiar with the GRADE evidence to decision framework or works, this was a project funded by the European Union called the DECIDE project that ran from 2011 to 2015, that the GRADE working group did with several partners, including WHO, NICE, and other groups. And we produced a number of articles that looked at multi-criteria decision-making or evidence to decision frameworks and how they can be used in different contexts, such as coverage decisions, in public health and health systems decisions, and in clinical practice guidelines, as well as how, for instance, linked evidence is utilized when recommendations about tests are made. Here is an overview, so that is what we produced. So the criteria for ETD frameworks for different types of decisions are listed here, how they actually relate together or to each other. Everybody asks, is the problem a priority? For test accuracy, one would obviously only ask this question more directly in test or screening or other types of recommendations, and so on. So all of these criteria being considered in the different types of decisions that are made. We subsequently produced GRADE interactive evidence to decision frameworks. This is a screenshot from GRADE Pro that shows that an evidence to decision framework has sections that include a question and background to the actual question, the assessment based on criteria, which I will focus on, a conclusion section that includes the type of decisions and recommendations, justification, and what should be considered under implementation, as well as research conclusions that can be drawn. And then we have different presentation formats that follow from that. And it is also clear that different perspectives can be taken, different decisions can be made, and that these interactive evidence to decision frameworks in GRADE Pro can be used to make group decisions in person or online. But having said all that, it is clear that there are more actors and more complex decisions. I will give you an example. Different health decision makers should be working together in terms of identifying outcomes that matter to people. Here is an example from a paper that we published in the Journal of Clinical Epidemiology in 2020, and that we intensified, on which we had intensified our thinking in the Lancet publication that I mentioned. It relates to question formulation and harmonizing the definitions of outcomes. So first of all, whenever a decision is made, obviously the outcomes should be people or patient important. Here, a quick note, we switch to the term people, as many patient groups prefer to not be called patients, but people living with a certain condition. And obviously the focus should possibly also be on patient or people reported outcomes. But at the center is what matters to people. This should determine how guideline recommendations look at outcomes, what outcomes are measured in randomized controlled trials and other interventions, what outcomes are measured in quality improvement and assurance, how systematic reviewers and health technology assessors look at outcomes, and how people actually communicate in clinical care, public health, and other decision-making contexts with people. And it is pretty clear that only if we have a clear understanding, definition, and approach to measurement can we start communicating better. And it will be also very clear that whatever is utilized in these different decision-making contexts as an outcome may not be exactly reflecting what matters to people. But the only way to know that is by having standardized outcomes, number one, and then to determine how directly the potential outcome that matters to people can actually be measured or has been identified, can be measured, for instance, in research studies, or has been identified in systematic reviews or health technology assessments. And One way of then saying the outcome was measured in the way that we intended it to be measured is by judging its indirectness. So for instance, if we're interested in quality of life that is generic, and researchers use a tool that is pretty focused on the condition, that may or may not be directly related to what matters to people. And those who do a systematic review, then bringing together many different quality of life tools, may say, well, they do measure what matters to people, or they may not measure it as detailed, and judge that in terms of indirectness of the outcome. One way to address that we have started to do is by using health outcome descriptors. This is from the European Commission Initiative on Breast Cancer, where we started to develop overarching definitions for particular outcomes. Here's an example of a false negative screening result. These health outcome descriptors, based on work that has been done over 20 years, include descriptions of what one feels or experiences, so in other words, symptoms, the time horizon, testing and treatment that may follow from a condition, and the potential consequences. We've done this not only for the breast cancer example that I showed you. We've developed over 100 of these health outcome descriptors in another big project that focused on venous thromboembolism, where we also developed health outcome descriptors for different degrees of expression of a condition. In this case, for instance, pulmonary embolism that we described as mild, moderate, and severe, with different descriptors so that people can actually relate to it. Health outcome descriptors follow or have a number of functions. First of all, they help with communication. Second, they help with calibrating those who make decisions. Third, they help with being very clear in terms of what one actually wants to measure. They help with judging indirectness, and they can be used in decision aids, for instance, again, around communication with people. There are other functions, but these are some of the key ones. They also serve in another example. This is also for the European Commission, or work that we did for the European Commission. So only by being very clear in terms of how an outcome is defined, for instance, in a PICO question, where there are several outcomes, one can then say, well, let's relate a quality indicator to that particular outcome. A quality indicator is a construct that is used as a guide to monitor, evaluate, and improve the quality of services. It can then relate to performance measures that we define in this publication as tools to quantify or describe measurable elements of practice performance to which there is evidence. They can be used to assess quality of care provided. And finally, we define what a performance indicator is, that is actually a measurable unit of practice performance for which there is evidence that can be used, again, to assess the quality of care that is provided. But you see here that through a definition of the outcome that relates to the PICO question, in this framework one can directly relate quality indicators, performance measures, and performance indicators. For instance, venous thromboembolism, the quality indicator would be actually, for instance, the occurrence of venous thromboembolism. One can measure how many of those occur and set indicators for when and how often they actually can occur, for instance, in hospitalized patients. You see that only through that are we able to communicate. And this connects, for instance, the field of guideline development, health technology assessment, with the field of quality assurance and improvement, as an example. With all this work being done in the background, again, this was done for the European Commission, as I mentioned, and is now being applied in colorectal cancer guidelines, as I will explain. From all of that, we developed our theory of everything. Again, this refers to this particular publication that I already mentioned. And here's how it works. So, there are questions in healthcare or in a healthcare system that identify the problem or populations, the relevant interventions, comparators, and outcomes in the PICO framework. Many decision makers operate under a legal framework, and that needs to be acknowledged. But what all of these groups are doing is they look at evidence from primary research. They utilize systematic review methods to produce health technology assessments, guidelines, quality improvement, make coverage decisions, select medicines for the essential list of medicines, and make evidence-informed policy. What we find, as I mentioned earlier, is that the evidence to decision criteria that these different actors use overlap largely for many instances, for many criteria. So for instance, all of these groups define if the problem is a priority or is important. Every group is interested in benefits or harms, or versus the harms. That also includes terms such as efficacy outcome and safety outcomes. That's the same thing. They're interested in what values people place on the outcomes. They're interested in cost, although obviously in a narrow context, a guideline developer may not be as interested in cost. And they are interested in the certainty that they can place in the evidence that describes all of these criteria. There is very little variation despite the fact that there's different terminology that is used. However, when it comes to other criteria, they are also labeled differently and they may have different importance or impact on the decision. So in HTA, the terms social, ethical, and legal considerations are often mentioned. In guidelines, equity, feasibility, and acceptability is of interest. Measurability and scientific soundness, which is akin or pretty much related to the certainty of evidence, are key considerations. For coverage decisions, the legislation around transparency may influence what criteria are used. For essential medicines, the pharmacopoeial standards and the regulatory status and market availability may be critical. Equity and feasibility will be key considerations for evidence-informed policymaking. Many of these disciplines use modeling to arrive at conclusions that then lead to recommendations, for instance in HTA and guidelines, or decisions, for instance in quality improvement and coverage decisions, or essential medicine listing decisions, or options, which is what evidence-informed policy, the evidence-informed policy field prefers. And obviously recommendations may relate to decisions. So for instance, a guideline developer or an HTA agency may make a recommendation that is utilized by others to make a coverage decision. A good example is, for instance, the German Common Consensus Conference, or the GBA, that makes decisions on the basis of HTA assessments, health technology assessments that the German Institute for Efficiency and Quality in Healthcare, IQWiC, is doing. This is a product, and that product is obviously then utilized by others for the actual implementation of the decisions. A special status goes to regulators. Regulators sometimes use systematic review methodology, but may not. And regulators, that relates to drug regulators as well as also environmental health impact regulators. They use many of these criteria, but use them in different ways. They may make recommendations or decisions, obviously, that then, again, relate to the products that the clinical world, the public health or health system will utilize to make decisions. And they implement them, as I already said. This in itself leads to evidence from primary research that concludes the circle of how primary research is utilized for recommendations, decisions, or options that are being laid out that then are implemented. This is our evidence ecosystem of health decision making that, as I said, we described in that Lancet publication. I will conclude with a few examples. So, first example is from the new European Commission initiative on colorectal cancer. It's called ECICC. In that initiative that is just being kicked off, there are several ecosystem elements that are being utilized. Systematic reviews, health technology assessments, including cost analysis, that will lead to recommendations We are using modeling in this initiative. Health marker states are being used. There's an integrated quality assurance scheme development, and this will likely lead to coverage decisions once it is implemented through evidence-informed policy. So a connection of all of that. Here's how this works. The European Commission has a colorectal cancer executive or working group that defines the PICO question, thinking about quality indicators right from the start. Our typical great way of thinking about it is that there will be systematic reviews that will focus on people-relevant outcomes related to colorectal cancer, quality indicators, and this will be identified, as I said, through systematic reviews and health technology assessments based on questions that have been prioritized by a panel. This will be synthesized. Evidence profiles, including quality indicators and performance measures, and evidence to decision frameworks will be produced in Grade Pro. The certainty will be rated for each outcome, including an assessment of quality indicators and performance measure and other criteria evidence. This will be utilized in an evidence to decision framework that includes the relevant criteria. The grade approach to making recommendations and coverage decisions will be utilized, making strong recommendations or conditional recommendations for or against an option. Quality indicators and performance measures will be identified. All of that based on, as I said, systematic reviews and health technology assessment. This will then be utilized in an integrated guideline and quality assurance scheme that, as I said, can be disseminated in Europe. What this also helps with is contextualization. So, as you know, Europe is a pretty variable geographic and jurisdictional region with differences in terms of, for instance, how colorectal cancer care is provided. This approach helps with contextualization of health decision making. So we describe contextualization of guidance as the need for dialogue and formal consideration of local best available evidence and criteria for adopting, adapting, or de novo creation of recommendations from an existing trustworthy guideline to the national, local, or other level. And it also includes in its definition to decide whether they are right for that setting, the recommendations, and modifying or adding to the recommendations to optimize their implementation using structured and transparent processes. Essentially, our ecosystem of health decision making, because a recommendation may lead to quality indicators that differ by context. It may lead to considerations around feasibility, cost, and coverage, and then the actual policy on a national level. So what I was referring to is that with these evidence to decision or recommendation frameworks, we are able to then say, okay, if we use a structured process for trustworthy guideline recommendations, here's a picture from the Gin McMaster checklist for guideline development that we've expanded for quality assurance and rapid guidelines, and are currently working on stakeholder involvement. When these processes are used, this evidence can be shared, updated, and collaboration across the evidence system can happen, as we've seen, for instance, with adaptation of the breast cancer guidelines to different contexts, including China. We'll give an example. That can be done through adaptation, adoption, or development of decisions, and then lead to implementation if the information that is provided is clear. So, for instance, going back, the European Commission also did an initiative on breast cancer. The evidence to decision frameworks were shared with the Tunisian government, the Ministry of Health, that rated these guidelines based on the AGREE tool as highly credible, to develop the breast cancer screening recommendations with justifications for changes to the source recommendations. And again, this was possible because evidence to decision frameworks were made transparent, available in that ecosystem, so that actually with supporting health technology assessments, this particular group in Tunisia could develop recommendations. This has also been done, for instance, in China, that used the joint research center of the European Commission initiative on breast cancer that I was referring to, the predecessor of the colorectal cancer initiative, that used all of these recommendations to then look at the local context after the evidence to decision frameworks were shared in order to make recommendations that are suitable, considering all the other evidence syntheses that are suitable for the context in China. So, in summary, what I've presented is a theory of everything that describes the ecosystem of health decision making, that allows to bridge gaps between disciplines, focusing on key decision criteria that are not only relevant for guidelines and health technology assessment, but allow to collaborate also with other actors in the health decision-making space. And I would like to thank my colleagues that helped develop this theory of everything: Margaret Raynapp, Thomas Piggott, Lorenzo Moyer foremost, together with Erki Leitme and Christina Köhler as the core group, and all of these other various disciplines representing individuals that have helped to put this together. Please contact me here, still on Twitter, although Mastodon is something that I'm considering given the developments in health politics and politics in general. Thank you very much.
Thank you very much. We have Schumann. Can we have Mr. Schumann? Please proceed with the video, please. Can Mr. Schumann turn on your video? Mr. Schumann, are you there? Can you hear me?
Mr. Schumann, please turn on your video, please.
Mr. Schumann, can you turn on your video, please? Do you have any questions from Zoom? Do you have any questions from the attendees for Mr. Schumann? Hello, Mr. Schumann. We have around 40 people, attendees in offline and online as well. If we have any questions from the attendees, we will be giving them the mic. Do we have any questions from the attendees? While you are thinking, Mr. Schumann might... Oh, we have a question. We have listened to your presentation very well. I have a question on the guideline. Is it personally reflected to the patients? The insurance is only proceeded to the group. Is there any difference with the insurance and the patients? They are not able to apply the insurance. But as a doctor, can the doctor initiate and let the patient know that there is something like this in the field? What do you think is the difference of giving them the choice of being able to do with an insurance and without the insurance? Do you think there's a limit of letting the patient know which equipment they are able to use for the procedure?
So do you want to summarize the question, Mr. Schumann?
I would love to answer. The translation has not come through. So I have not heard the translation.
다시
If somebody could repeat the question for me, I'll be extremely happy to answer.
통역은 해주시는 거죠? 다시 좀 간단하게 질문을 다시 드리면 보험은 안 되지만 개인 의사로서 환자한테 이런 기술을 적용해 볼 수도 있다라고 제안할 수 있는 그런 기술이 있을 때
Even though they are not able to get the insurance for the process and for the guidelines, can we let the patient know that they also have this choice even though the insurance is not covered?
그럴 때 그런 의사결정의 차이를 일으키는 가장 중요한 요인이 말씀해 주신 여러 가지 것 중에서 어떤 것
What do you think the doctor should be able to know when to initiate to let the patients know about the possibility of this program, even though it's not covered by the insurance?
If I understand the question correctly, it is about when there are interventions that are not covered by insurances or other forms of payments, and whether or not that is something that should be disclosed to patients. So if I understand the question correctly, in a decision-making context, interventions that are recommended for whatever reasons, with or without coverage, should of course be disclosed as a possible intervention that people can or should receive. That decision is probably based on anything but can include costs and cannot include costs, and is primarily focused probably on whether or not there would be more benefits than harms from an intervention. Now, patients should also be informed about alternatives that may be equally effective or may have greater benefit in order to make informed choices. But if I understand the question correctly, my sense is that patients should always be informed about the possibility of an intervention, whether or not it is covered. If I understand the question correctly, that's how I would think we would want to act, right? Because patients can always pay out of pocket if their values are such that they would spend resources even on interventions that are not covered by insurances.
네, 답변 감사드립니다. 잘 이해됐습니다.
Thank you for your answer. You have understood my question very perfectly. We have a question from YouTube. Preference indicator and a preference indicator. Could you give me an example of those two?
Again, there's an issue with the simultaneous translation. So if you can repeat the question, the translation the audio is not coming through. Can you please repeat the question?
네, 퍼포먼스 인디케이터와 퍼포먼스 메저의 개념의 차이를
Can you give me an example to understand PM and PI?
So let me perhaps take you through the quality indicator and the performance measure and performance indicator. So one of the big confusions has been in the quality assurance and improvement field, the actual terminology. So what we did in this paper that I cited there, we try to first of all clarify terminology and bring clarity to the actual field of what the individual terms that are utilized are connected with. So one way of thinking about it is, let's just say that the measurement of or that quality of life is a critical outcome in a intervention question. You can think of quality of life as the actual quality indicator as well that might be a result of introducing a new intervention. So the quality indicator or the domain, the construct is quality of life. Now you can think that the appropriate way of measuring quality of life may be a particular instrument. For instance, using the SF36 or the Health Utility Instrument Index as your actual performance measure. So quality of life is your quality indicator. The performance measure, in other words, how you measure the performance of the quality indicator, is a specific tool that you might identify. In this case, the SF36 or the Health Utility Index as examples. The actual performance indicator then that one can determine is that with a certain intervention, the actual performance measure must improve, and it must improve by a certain amount. That would be your actual performance measure there. So that is one way of conceptualizing the different terms and how a important outcome can be directly related to the actual measurement of quality. So a quality indicator is a construct, for instance, quality of life, or let's say the occurrence of venous thromboembolism. The performance measure is the tool that helps to quantify that particular construct. So for instance, the SF36, and the performance indicator is how good or how much you actually want to achieve, how much improvement you might want to achieve after an intervention is introduced. Over.
네, 감사합니다.
Thank you very much. Do we have any question? We have one more question. Thank you for your presentation. What I would like to ask is,
되고 그래서 굉장히 방법적으로 복잡해질 수밖에 없는데 그래서 그런 위험성을 감수하고라도 어댑테이션이라고 하는 방법론이 잘 적용된다고 생각하시는지 아니면은 아예 그런 것들보다는 조금 더 새롭게 SR을 다시 하는 것이 좋겠다고 생각하시는 건지 좀 설명을 부탁드리겠습니다. 네.
So here's the question. You gave us examples and explanation about adaptation of the evidence. And I understand this could be a good alternative if this is a region or country with scarce resources. However, I'd like to ask, when it comes to real implication, can we really take to chance? Can we really take the chance at the risk of uncertainties? Because then if else, we have to think about the risk, and there is a chance that at this point, this whole research and data may be outdated. But still, even under these circumstances, do you think it's better to adapt to a certain regions, or we develop a whole new SRs and ATA?
Okay, so I would have said that whenever you adapt information that has been prepared for other contexts, you need to check if the information is outdated. That's the first thing. If the information is outdated, then the way that modern adaptation should work is that you have access to the original information, access to the original methods, and that you can use the original methods to ensure that information is up to date. I'll give you a very specific example. We have, on a number of occasions, worked with those who were interested in adapting, for instance, guidelines and shared all of the original material to the extent that those who conducted the adaptation were able to reproduce the searches. So for instance, if information was up to date up until say July 2020, those who adapted had access to the information and were able to bring it up to speed to say October 2022. That is, that is how this should work, that the information is transparent enough, the systematic reviews are transparent enough that you can utilize information and update it if it should be necessary. In many instances, it may not be necessary to update because the information is utilized right after it is made public. And where the adaptation comes in is in the factors that requires contextualization. So the principle of adaptation is very much founded on being able to share the results of a systematic review, but also its methods so that those who adapt can actually use the same approach to understand if new information that might change conclusions is available. So the sharing of the original, both results as well as strategies, is a critical piece in adaptation. And even if it's not shared, it should be transparent enough that others can check if new information is available. So adaptation always should go with understanding if it is still up to date. Over.
Thank you very much.
Thank you very much, Professor Schumann. Next, we will proceed to the next presentation. Mr. Schumann, you can stay comfortably, and if you would like to exit, that will be also good as well. Thank you very much. Next, we have Japan from Mind Center, Akiko Okumura professor. She has a background of clinical evidence research in Japan Council for Quality Healthcare. She is the Minds Guideline Gallery General Manager. Let's proceed with the video.
Hi, my name is Akiko Okumura. Can you hear me? Okay. I appreciate the opportunity to give these presentations. I am Akiko Okumura in the Department EBM and Guidelines at Japan Council for Quality Healthcare. Today, I will be speaking on our activities, development and implementation of guidelines in Japan. disclosures of COI. In connection with these presentations, there is no direct financial COI to be disclosed with any relations. I will divide my talk into following three parts: MIND's activities, guidelines development support, challenges, and countermeasures for the future. Firstly, I will talk about MIND's activities. In 1999, the ministry decided to help develop guidelines for diseases of large burden in Japan with grant in aid from the ministry. In 1902, non-profit third-party organization for quality improvement in healthcare launched the EBM promotion project funded by the ministry to disseminate guidelines developed in Japan. The project is now based on consignment of ministry since 2011. JQ operates 6 projects shown in this page, mainly hospital accreditation, one of which is MIND's EBM and Guidelines Promoting Project. These diagrams indicates MIND's project concept. MIND's mission is supporting patient and healthcare professionals' decision-making through the provision of medical information centered on reliable guidelines, contribute to improving the quality of medical care. Key components of MIND's project. First, support for guidelines development. Second, evaluation, selection, publication of guidelines. Third, promotion for utilization of guidelines. Fourth, support for patients and the public. This is the top page of our project website called MIND's Guideline Library. Let me share with you our website. Sorry, it is in Japanese. You may not be able to follow, but this is our project website. Using the search box, users are able to search the guidelines. We post about 800 guidelines and 150 commentaries. The characteristic of MIND's guideline library as shown in this page. Posting guidelines selected by a comprehensive search and systematic evaluation using AGRI2. And also posting the commentaries and information on COVID-19 guidelines and guidance. Also, we have pages for guideline users and guideline developers and patient or public. This is procedures for evaluation, selection, and publication of guidelines. First, literature search and screening. A two-stage screening process was performed for guidelines identified by searching the database of literature. We have searched Japanese guidelines using 10 major databases since April 2011. Second, evaluation using AGRI2. The guidelines identified by the above procedure were evaluated by the guidelines evaluation group using AGRI2. One guidelines was evaluated by 4 evaluators. In November 2016, we started to use reporting checklist 2 in addition to Agri 2 in order to reduce variations among the evaluators. Third, selection by guidelines selection committees. Based on above Agri's evaluation results, potential guidelines for posting on MIND's website were selected by the guideline selection committee composed of external panel members. Fourth, evaluation feedback. We prepared feedback reports of Agri 2 evaluation result for the guideline development group. The feedback report is composed of Agri 2 domain scores and advice for improving the quality of guidelines. Next, I will talk about support for the guideline development. This is the factors affecting the quality and trustworthiness of guidelines. These are important points in guideline development. We conduct these supports in guideline development. First, MIND's handbook guideline development. Second, guideline development workshop. Third, comprehensive consultation service. For example, email consultation and consultation meeting. Fourth, activities MIND's Tokyo Grade Center. Fifth, guideline education program. First, about MIND's handbook of guideline development. We began to develop MIND's handbook for guideline development in 2006. The first edition was published in 1907, followed by 3 revisions, and the latest edition was published in last year. This is latest version contents. In the most recent revisions, the health economic evaluation was newly included in Chapter 5, and the item of the patient public involvement was added in Chapter 2. The contents of PPI items in Chapter 2 is shown in this page. We contain importance, policy, and method of PPI, and also approach to PPI. Next, activities as MIND's Tokyo Grade Center. MIND's Tokyo Grade Center is an organization established to disseminate the grade approach in Japan. It was established by JQ based on approved by G3 in March 2019. The main activities are as follows: holding seminars, workshop to disseminate the grade approach, proposals on how to develop guidelines in Japan, including the grade approach, activities to contribute to development of guideline of a grade approach. Finally, I will talk about challenges and countermeasures for the future. This is an illustration of a well-known evidence ecosystem. To develop reliable guidelines, GDG takes a lot of effort and time. For the GDGs and users of guidelines, the efficiency of development of guidelines is a pressing issue. Based on these circumstances, we have been working on ICT project since this year. This project is to standardize guidelines data so that guidelines can be introduced into medical information systems as dynamic medical information data. We will address the following task. First, development of terminology used in guidelines. Second, suggestions for basic formats for guidelines. Third, investigation of new guidelines, classification, and identification methods. Fourth, improving and coordinating ICT. And finally, I would like to refer to Mind's challenge and future prospects. First, expansion of reliable medical information. For example, division between guidelines and guidance. Second, dissemination of understanding and appropriate utilizations. Third, improving the coordinating ICT and enhance convenience by utilizing ICT. And drafting efficient guidelines development and publication method. And human resource development. It's all. Thank you for attention.
네,
Thank you very much, Okumura, for doing a presentation with us. If anyone has a question, you could raise your hand or you can send us your questions.
오쿠라 교수님 저기 마이크 카메라를 이렇게 온 해주시고요. 네, 실시간으로 들어와 계십니다.
Thank you very much for coming in live. In Japan guideline, I have heard a lot of things. The first thing I want to ask is that the Mind's technology is included in the industry. Is there any? How do we get funds and how is it processed? In Japan, we heard that you are selling them to the doctors in Japan. How much % does it have in the funds?
I'm sorry, sound is too small.
Okay, I'll give you the question once again. We heard that Japan.
The nature of mind. So I heard it's a kind of public organization. So I want to know about the funding source of the mines. And I heard that Japanese doctors may buy the CPG. So what is portion of the selling the CPG in mines?
Ms. Okumura, were you able to hear?
Difficult to hear the English.
Ms. Okumura, can you hear me? Okay. 그럼 let me recap the question. Please hold on. So, Ms. Okumura, the question is, I'd like to know about the nature of mind. So I heard it's some kind of foundation. So what I want to know is that how is it operating and what is the constitution of the human resources of this organization called Mind. And also in addition to that, if I understand correctly, I understand that in Japan, the Japanese doctors can buy these kind of guidelines. So if I may ask, for these sales, how much these sales count for the total funds of the mines?
Thank you for questions. Mine's member is JQ's members, and I showed my slides. Okay. Mines is one of the activities of JQ. So Mines member is not isolated, and JQ's members, and JQ is the third parties and main project is hospital accreditation, and this project, EBM and CPG promoting project, and a project to collect medical near-miss adverse event information, and also project to collect and analyze pharmaceutical near-miss information. These are funded by ministry, and also hospital and first hospital and functional assessment, and a project to promote patient safety is JQ's found by JQ. Okay.
네. 그러면 사실 시간이 좀 이제 많이 모자라서 저희가 추가적인 질문을
We don't have any remaining time for more questions. We will have them collected and ask them for Ms. Okumura to answer them afterwards. And Ms. Okumura has to leave as well. We will contact her after. Thank you very much, Ms. Okumura. Next, I will be continuing the presentation. Let me introduce myself. I have been working in Neca, Korea for 11 years. I have started in systematic reviews and health technologies to grade approach methodology. I adore the grade group. Okay, can we have the slide presented, please? I would like to have introduce you about our Neca. In Korea, we have 51.7 million currently, and we have a healthcare services, and it has been extending through world to Korea all over. Our Neca has been researched. It's a government research agency, and our role is for clinical assessment. If you see our mission, you could see the medical resources and national health promotion for providing scientific evidences. That's our mission. If you can see, this is our role in the HT life cycle. We have been doing it for processes. The main role we have right now is we are a research agency. Our HT is an assessment or procedure. Support for evidence creation for conversation. And we have been doing a scenario monitoring. And we have been doing a chemical scientific statuses to process. We've been approaching them for the process.
그리고 의료기술 전투에서
And for the clinical technology assessment,
저희가 이제 시장에 진입한 기술
we have gone to the market for assessment.
저희가 이제 평가 필요한 부분에 대해서는
We have been doing research, and
그리고 좀 더 말씀드리겠지만
if I will be explaining more onwards.
업무를 수행하고 있고 또 환자 중심
And we have been doing it directly, focusing on the practices for the patients.
굉장히 빠르게 소개드려서 죄송하고요.
I'm very sorry that we have been doing this very quickly.
방법론을 적용하고 있는
We are doing great guideline methodology. We have two businesses. We have clinical and HT.
평가에 대해서 말씀드리겠습니다.
First of all, we will doing it for the clinical first.
이제 사전 신청하신 분들께 책자 인쇄 파일 PDF로 보내드리고
For the slides, we will be sending them afterwards. If you would like to read on the further details, you could get them online.
저희가 수행 목적이 조금씩 다릅니다.
The rules, we have it very differently.
예, 부분. 그다음에 비급여에 대한 부분.
We have been insurance and we have non-funded insurance.
수행 방법과
We have different processes for both and different
진행 중인 사례들도
examples for both as well.
슬라이드가 바뀌지 않아서 죄송합니다. 그렇고 이제 저희가 너무 죄송한데 제가 메인 실수를 해서 죄송합니다.
그래서 행위급여,
We have reimburance, contribution coverage, non-covered services, episode non-covered services.
사례를 진행을 하고 있고요. 그리고 이거는 저희가 이제 여러 방법으로 수습합니다.
And we have different topics collected,
거치고
and it is screened, and it's going to a different research evaluation.
수습 평가를 그레이드 방법론으로 적용.
We do it collaborating with the GRADE guideline,
이제 건강 이제 보험
with the health insurance
하고 사업 모집
file has been sent, and we have been collaborating with that as well.
네, 저희가 메소드별로 보시면은 시스템 리뷰,
If you look at the methods,
건강보험 자료를 이용한 분석 연구
we have defining the scope of reassessment, approval for reassessment plan with HDR committee, reassessment review by HDR committee, and reporting. We have been applying them depending on the cases.
공고에 대해서 저희
With the GRADE guideline,
공고하는 것
we have been announcing them.
또 이제 불충분한 공고 그다음에 공고하지 않는 것 이렇게 이제 평가를 하고 있고요.
We have been doing data analysis research, systematic outcome research, and sending them out for asking them for their collaborations.
그래서 이제 저희 재평가에서는 저희가 이제 네카는 독립적인 연구기관
For evaluation of the NECA, we have been doing them transparently.
그리고 이제 정규직 연구원
For the full-time researchers and trained methodologies are been placed.
함께가
Real-world data
진행하는 점이 강점이고요. 또 데이터를 연결시킬 수 있는 그런 권한을
and for the real-world data, we have been jurisdiction for the health data linkage.
저희가 좀 이제 제한점이 있는
But we do have limitations as well.
것과 연결될
It is also connected to the insurance providers
수 있는 부분들이 있어서
and the clinicals.
특히 이제 조금 낮은 근거 수준이나
We have a low evidence level in concerning this,
나타내시는 경우가 있습니다.
which is why they have trouble connecting with this.
천천히 제가 마음이 급해서 제가 마음이 급해서 너무 빠르게 진행해서 죄송합니다.
I am very sorry that we have been doing this very speed.
의료기술 평가는 저희 네카에서 수행하는 거라서 저희 기관의 활동을 소개드리면 됐는데 저희가 그 임상진료 지침에 대해서는 이제 저기 현장에 계시는 저희 할머니들 김수영 교수님을 비롯한 대한의학회 JKNS 제 캄스 대한의학회와 함께
We have been researching with the JChem camps every year in Korea for around 20 times. We've been collecting this for 5 years. It had lacked for public funds, and we had a lack of human resources for methodologists. Because of this, we have the lack of this. We haven't been announced that we only did 60% of the grade approach. But if we included more, it is a low percentage compared to the other items. The most difficulty they had with is the definition, grade certainty of evidence, grade ranking of certainty consistent with the definitions. We all have this outcome, and this all showed had a low compliances. We have the methodologist manuals coming up. In 2011, we have the first systematic review manuals, and we introduced the grade approach. In handbook for 2011, we have introduced the grade introduction. We have updated it recently, and it had all the information for the grade guidelines. We organized in separate part, but what's included in development chapter to reflect the recent changes. And we've been implementing and utilizing of the clinical practices guidelines were supplemented with practical contents and examples and more specific guidelines. It is the new manual and it has a lot of contents. It has not changed significantly. The how-to section is described in the order of the development process so that it can be applied in the national development field. In addition, cases of clinical practices guidelines recently organized by the Korean Medical Associates have been added. From 2011, Neca has been funds, and we have been connecting with the official MOUs, and it have been going for national and internationally. And we have a training inside this book manual. And in guide methodology, we have gotten the certificate. Level 2 is a methodologist clinics. 2011 in guided course. We would like to show you the CAMS trustworthy collaborations. We have started in 2020, and we've been doing the COVID-19 living guideline, and we've been extending it with collaboration. If you can see with this guideline, this is all proceeded with the Neca researchers. And DUA focusing on these specialties are the clinical experts. And we've changed our homepage, and we've been updated and proceeded the new guidelines. We've been doing workshop approach educations for trainings, and we will be proceeding them internally and externally researchers as well. And we will be focusing on the guidelines approach. And we will be investigating so that the grade guidelines will be even further practiced in Korea. There are a lot of materials in English, but we will be translating them in Korean as well.
당황해서 그랬습니다. 네, 혹시 질문 있으실까요?
Do we have any questions?
저는 나중에 언제든지 질문 주시고 저희 오래 기다린
If you have any question, you can give them to me. And next, we will have the presentation for Heath White. Next, we will be joined by Heath White. Likewise, Mr. White has numerous titles. He is the Senior Evidence Officer of Cochrane, Australia, Monash University, and he is the Living Guideline COVID-19 leader. I was in debt to him when I was visiting the Australian research and still been pestering him in Korea. We will show you the recorded video first, and the questions will be asked afterwards.
Good morning, everyone. My name is Heath White. I'd like to start by saying thank you, everybody, for inviting me to this fantastic group of talks this morning. I am the evidence lead at the National Clinical Evidence Task Force at Cochrane Australia Monash University, so based here in Melbourne, Australia. And I'd just like to talk to you today about the application of grade methods in the development of our COVID-19 recommendations within the task force. So I'll give you a quick overview of the presentation. I will touch on who we are at the task force, and I will discuss living guidelines in a little bit more depth, but not too much depth, because you've probably all heard of it before. I'll just touch on grade, how it's normally kind of done, how it's normally applied, and how we've applied it to the development of COVID-19 recommendations within the task force. And then I'll give you some conclusions and final thoughts at the end. So what do we do? So over here at the National Clinical Evidence Task Force, we essentially bring together 35 peak professional bodies across Australia to support Australian clinicians with continually updated evidence-based guidance for the clinical care of people with COVID-19. We used to be called the National COVID-19 Clinical Evidence Task Force. We've since renamed to the National Clinical Evidence Task Force because we are actually looking at monkeypox or MPX living guidelines as well at the moment. So essentially, we provide national evidence-based guidelines for the clinical care of people with COVID-19. So we're not focused on infection prevention and control, epidemiology, things like that. It's just the clinical care of people with COVID-19. We do this by undertaking continuous evidence surveillance to identify, and then when we do identify, to rapidly synthesize research every week. And this essentially gives us the ability to offer a trusted, unified national clinical voice to provide reassurance to clinicians that they are actually using the best available evidence and they are making the best decisions for their patients. So living guidelines, why do we do it? Again, I won't spend too much time on this, but conventional guidelines, as you know, are updated generally every 3 to 5 years or thereabouts. In the current model, of course, you actually have to develop the full guideline from scratch, and obviously this can take a lot of time and actually cost a lot of money. And then by the time you actually finish developing the guideline and you're actually into that implementation phase, it might be out there for 5 years. So when the recommendations become outdated due to new evidence, or if there's any changes to policy or practice or new products in market, the current traditional guidelines are unable to capture these until the next iteration. So you can't actually include this information until you update the guideline and then republish. And then, of course, the currency continues to diminish over time. With living guidelines, of course, you still need to develop the baseline guidelines. These might be just done from scratch, or might be adapted or adopted from existing guidelines. But then once you have that static or traditional guideline, then you can update those recommendations continuously. So if there are any changes to policy and practice, new products in market, etc., new evidence being generated, you can ensure that you always have the most up-to-date information available. So the currency and the reliability of the guideline remains high. So within the task force, as I mentioned, we do focus on the management of COVID-19, so the treatment and care of COVID-19 specifically, and we cover the full disease course, so anywhere from mild, moderate, severe, all the way through to critical illness, and we did also look at some prophylaxis, so prevention as well at one stage. We do update with new research in near real time in order to give reliable up-to-date minute advice. And of course, it's been very critical, and we've had lots of positive feedback in Australia about this because clinicians can actually trust what they're reading and apply the most recent evidence. So I'll just touch on this. You've been through this before. So with the grade method, we can break this up into 2 components. Essentially, you've got the evidence synthesis component and the actual formulation of the recommendations themselves. So initially you have the panel who all come together and they formulate this clinical question. So you look at the population, intervention, comparative outcomes, the kind of standard protocol for most questions. They also have to select the outcomes they're interested in reviewing and also rate the importance of these outcomes. So some might be critical, some might be important, some might not be very important, and thus you won't even look at these outcomes. And then once you have the clinical question and you've selected the outcomes and rated the importance, then you can do your search, identify all of your studies that relate to this clinical question, extract the outcomes, and formulate a evidence profile or a summary findings table, which gives you the absolute effect estimates for each of these outcomes. Now, in kind of standard grade mode, you would actually rate the certainty of evidence for each of these outcomes. Obviously, they can be high, moderate, low, or very low. Obviously, randomized control trials start off quite high, observational studies start off quite low. And then, of course, you can upgrade or downgrade these effects based on a variety of different factors here. So essentially, once the panel's looked at the evidence profile, we've assessed the certainty of evidence for each of these outcomes. We grade the overall quality of the evidence across the outcomes based on the lowest quality for the critical outcomes. And then the panel use these to come up with a recommendation either for or against a particular treatment, for instance, and it can be a strong or a conditional recommendation in either one of these directions. But of course, it's not just the evidence. You also do need to consider a few additional factors, such as the evidence to decision factors. And so you've got the certainty and the balance of benefits and harms, but there may also be patient preferences and values. You might seem to look at resource costs, equity, acceptability, feasibility, and these kind of other factors to determine what recommendation you should make. So once you've looked at all of this data together, you will develop your recommendation. That can be kind of for or against, or it can actually be an only in research recommendation. And unfortunately, in the task force, we've made quite a few of these because there's often insufficient evidence to determine whether a treatment works or does not work. And so hence we'll have an only in research recommendation saying we need further evidence. So applying the grade to the COVID-19 recommendations, I'll go through each of these stages as we've used it. So obviously formulating the clinical question itself, then selecting those outcomes and rating their importance of these outcomes, developing the evidence profile or summary findings table, and also rating the certainty of the evidence as it comes through. And then of course, deciding when to recommend or not recommend a particular treatment, considering factors such as the evidence to decision elements, as well as the clinical evidence, and using these to draft the final recommendations. So formulating the clinical question, obviously the very first step of any guideline development process, coming up with the PICO question. So if we look at kind of the traditional way, you'll have your steering committee or your guideline development group, or it could be a combination of both, that come up with this clinical question before you've looked at the literature, before you've done any other additional work. This is always predefined. So they establish this, as I've mentioned before, the literature search is conducted, and it has to be very specific. This example here is for diabetes. I also do work in living diabetes guidelines. And one of our panel members at the beginning actually asked, well, the question they're interested in is, what's the most effective treatment for type 1 diabetes? And yes, that's a fantastic question, but it is extremely broad. And so that, takes into account multiple populations, a numerous amount of treatments. And it's just not a very defined PICO question. It's very, very difficult to answer in under 1,000 pages, quite frankly. So you'll have your very specific criteria. For population, it might be adults with type 1 diabetes. For the intervention, you might be looking at hybrid closed-loop systems that consist of a continuous glucose monitoring device, which is linked to a continuous insulin infusion system. And you might want to compare this to the standard kind of pinprick method of measuring blood glucose, so self-monitoring of blood glucose, and also manual multiple daily injections of insulin. And for outcomes, these will all be predefined as well. You might be looking at changes in glycated hemoglobin, weight, serious adverse events, etc. So generally, you'll have your very defined PICO before you've done anything. And it might be, what's the comparative effectiveness of hybrid closed-loop systems consisting of a continuous glucose monitoring device linked to a continuous insulin infusion system, compared with self-monitoring and multiple daily injections in adults with type 1 diabetes. So again, very, very defined PICO question. Of course, diabetes falls into the established topic area of this chronological kind of chart here. So you can see, obviously, diabetes is an old condition. We've known about it for quite some time. We've developed multiple treatments. There's an abundance of evidence specific to diabetes. There's been multiple guidelines out there about diabetes. It's kind of a known factor. And so when you develop those PICO questions, you already kind of know what you're going to come up with. For COVID-19, it was completely different. We identified the condition, we knew COVID-19 was a thing, but there were no treatments available for it. There was evidence being generated, but there was no evidence available. And so there was a huge black hole when it came to knowledge. So we started by defining the scope prospectively within the steering committee. So the steering committee got together and said, all right, we want to look at recommendations specific to the treatment and care of individuals with COVID-19. We're only going to look at high quality evidence, so randomized controlled trial evidence for the use of drug treatments. But we might look at indirect high quality evidence, for instance, SARS, MERS, maybe even influenza, or observational evidence for other areas like respiratory support, recommendations, etc. And so we had kind of an iterative formulation of PICO questions based on the identified evidence. We had to kind of wait for the RCTs to be published, then look at those and kind of develop a clinical question based on the evidence. And this was done on daily searches. So we've done daily searches to identify this evidence and made these PICOs as it came through. So here's just one example. This was one of the early trials published within the COVID-19 pandemic. This was in April 2020, looking at remdesivir in patients with severe COVID-19. So I've just highlighted some areas here. As you can see, we looked at adults 18 years and over with laboratory confirmed SARS-CoV-2 infection and moderate to severe illness. We looked at remdesivir, so intravenous administration 200 milligrams on day 1 and then 100 milligrams on subsequent days up to day 10 versus placebo. And these also included standard care, which, as you can see, can include the concomitant use of lopinavir, ritonavir, interferons, and corticosteroids. So it was a bit of a mixed bag of standard care. Outcomes, though, these were all predefined. So I'll just touch on that now. So this is the kind of second phase here, the kind of selection and importance of outcomes. At the start, so it was March 2020, the end of March 2020, when the task force was formed. This was before there was any RCT evidence available, and we knew that it was going to be a month or two before we actually had those trials coming through. So the first few meetings we had with the drug treatment panel and the guidelines leadership group, we used to determine the scope of outcomes within the trials that we were going to look at, or select the outcomes. So we presented a list of outcomes to these panels and asked them to rate the importance. So which ones were critical, which were important, which were not important. And they kind of had to define these as we went along. We also had 2 meetings with the drug treatment panel to determine the minimal clinically important difference of the potential benefits we might see. And so obviously statistical significance is very important, but clinical significance is also very important. So when we looked at the critical outcomes, so all-cause mortality, the panel decided essentially 25 fewer deaths or greater was considered clinically significant. For the other critical outcomes we had, which was mechanical ventilation or respiratory failure ARDS, they thought about 30 fewer or more per 1,000 was clinically significant. And for the other important outcomes, it kind of varied slightly, but generally about 35 fewer or more per 1,000, depending on the outcome. And so before we had our first randomized control trial, before any of the evidence started to come in, we had already defined which outcomes we were interested in looking at and defined the minimal clinically important difference of these outcomes. And so creating the evidence profile itself and summary funding table and rating the certainty of evidence. This is an example of an evidence profile from MagiCap, which is the online publishing platform we use for our guideline. As you can see here, we define our outcome to the left. So we have our critical outcomes, all-cause mortality, invasive mechanical ventilation, and things like serious adverse events were considered important. Obviously, we have our statistical significance here, 0.93 to 1.04, so this was not a statistically significant outcome. And as you see here, 5 fewer deaths per 1,000, it wasn't a clinically significant outcome either. And so hence, convalescent plasma in this case, there's no important difference between treatment with convalescent plasma and standard care with regards to impact on death. And the same here with invasive mechanical ventilation. And so rating the certainty of evidence. So this is one of the drop-down menus from MagiCap. One of the things with rating the certainty of evidence is, of course, it is always a subjective assessment. You might come close, you'll look at the exact same information, you'll have the same evidence in front of you, but 2 different people can come up with 2 slightly different assessments of certainty based on their interpretation of the evidence or the thresholds they use. So for instance, what constitutes a risk of bias? For instance, here, it might be, for instance, incomplete data is one of the big ones we've kind of considered. You know, what if 5% of patients are lost to follow up without any information provided? Is that enough to downgrade for risk of bias? Or do you need 7%, 9%, 12% of patients? How many patients is enough to downgrade there? Again, point estimates, how much do they need to vary in order to downgrade for inconsistency? So again, if the CRs are not overlapping, is that significant enough? If the 95% confidence intervals overlap, then can they get away with it, or are you going to downgrade? Again, it's a little bit subjective. How different do the populations need to be in order to downgrade for indirectness? So within the task force, obviously, most of the trials are just focused on adults. And so usually if it's just a single trial or multiple trials with only adults, we'll downgrade for pregnant patients or pediatric patients based on indirectness. But then if pregnant patients are eligible for inclusion, even if there's only 1 or 2% of patients included in the trial that are pregnant, we might not downgrade due to indirectness because they were part of the trial. Also, how wide is too wide with regards to confidence intervals? For us, we used a rule generally of about 50 points. So if it was 25 fewer to 25 more per 1,000, if it was tighter than that, we probably wouldn't downgrade. But if it was more than that, so if it was 200 fewer to 200 more, that's very wide confidence interval. So we'd probably downgrade. And also how many patients are needed to prevent downgrading for imprecision. So again, if you have a trial with 400 patients, is that enough to actually give a positive recommendation, or is that slightly too few patients? How many patients do you need to trust a trial or a group of trials to not downgrade due to imprecision? And so I think the key with this is, of course, is just use logic and be consistent. So I think we'd all agree that a single trial with 50 patients is too few patients, for instance, to give a supportive recommendation based on that information. You need more data. Whereas if you say, no, we really need 10,000 participants to be sure of it, that's probably a little bit too extreme. So you wouldn't look at a trial with 5,000 patients and downgrade due to imprecision. And just be consistent. So make sure you apply these rules across every evidence profile, across every treatment, across every recommendation that you review to be consistent. So rating the certainty. So as you can see here, these ones are high. So we have over 16,000 participants here with 15 studies and 12,000 from 4 studies here. So we consider this high, tight confidence intervals, etc. For serious adverse events, we did downgrade once. And again, this is a convalescent plasma example. So we downgraded due to serious imprecision because these confidence intervals were sufficiently wide. And for adverse events, we downgraded twice. Once due to risk of bias, because none of the studies assessed the baseline neutralizing antibody levels within the included participants. The panel thought this was a big no-no. And of course, the range was extremely wide. And of course, I don't know how to get over 1,800 more in a maximum of 1,000, but this is very interesting. And so I only use the standard nomenclature here as well. So if the certainty is high, we would say it has no impact. If it's moderate, you'd say it probably has a little impact. If it's low, you'd say it may. So either no caveat included, or if it's moderate, you'd say probably. If it's low, you'd say may. And so this is just a convalescent plasma example again. So I've shown this slide in previous presentations. So obviously in June 2020, we had a single study with 100 participants. And we had no idea whether convalescent plasma works. We had very low certainty. This trial had issues with blinding, and there was also very serious imprecision. Then over time, as we added additional studies, we went from very low certainty to low certainty. And so we asked the question again, does it work? Maybe not. So the evidence suggested that it might not work, but we weren't certain enough that it didn't work. And so we still had serious risk of bias based on these studies not being able to provide baseline neutralizing antibody levels. And there were also wide confidence intervals. So we still downgraded the critical outcomes to low certainty. So we weren't sure if it worked or not. But then in April 2021, the recovery trial published their results looking at convalescent plasma. And we asked the same question, does it work? And we were quite confident, no, it doesn't. So we had high certainty. So the risk of bias was diminished because recovery provided baseline antibody level information, and the imprecision was there. Imprecision was not there, so there was no imprecision because these confidence intervals were shrunk substantially down to a range of 28 and 24 for mortality and mechanical ventilation. So we were quite confident that no, it did not work. So when we look at kind of grading the recommendation, so giving a recommendation for or against and the strength of recommendation, and also using the evidence to decision factors to actually determine what recommendation we make. So here, this one here is tocilizumab. So this is one of the ones we've looked at obviously quite recently and have continued to look at. It's one of our high priority recommendations. You can see here 2 critical outcomes that we've provided information for, mortality and mechanical ventilation. We have several thousand patients from multiple studies for both of these. As you can see, it is statistically significant benefit, so 0.8 to 0.93 and 0.7 to 0.9, and also clinically significant. So there's 39 fewer deaths and 41 fewer patients requiring mechanical ventilation per 1,000 who receive tocilizumab versus those that do not. So we had high certainty evidence that tocilizumab provided a benefit with these outcomes, and it also appeared as though it had a good safety profile. So we had, again, just reiterating here, we had high certainty that tocilizumab decreased all-cause mortality and need for invasive mechanical ventilation slightly, and moderate certainty evidence suggesting an acceptable safety profile. So these are quite promising results. Of course, when we factor in the evidence to decision information as well, we provide just a balance of benefits and harms and certainty. For preferences and values, all of our recommendations are actually presented to a dedicated consumer panel within the task force, and they provide input with regards to patient preference and values. We don't have an in-depth review of resource considerations because we do base these far more on clinical evidence. Equity, we do include some text with regards to equity of administration based on geographical location, for instance, rural and remote versus metropolitan hospitals, and also ethnicity. So, the disparities between Aboriginal patients versus non-Aboriginal patients. The acceptability, we don't have any in-depth review of this, and also feasibility. Again, we don't have an in-depth review of feasibility, but we do generally include information with regards to access to these therapeutics based on the approval or the availability of them within Australia. And for instance, with tocilizumab, we did suggest that clinicians consider using baricitinib as an alternative because there were quite wide shortages of tocilizumab within Australia earlier this year. So when you formulate the recommendation, again, if we look at the overall body of evidence, and again, this is for tocilizumab, we look at the overall body, so the number of participants from the number of studies, the direction and the significance of the effect for the critical outcomes. So obviously these are statistically and clinically significant benefits. When we look at the certainty of the evidence supporting the absolute effect estimate, this was higher certainty with both of these outcomes. Consideration of the balance of safety concerns, as I showed on the previous slide, I haven't included it here, but there were no safety concerns. It's been used quite frequently within Australia for other indications for quite some time. And then also evidence to decision factors. And again, there was nothing that jumped out here with regards to the use of tocilizumab within Australia, except for that brief shortage early in the year in which we suggested clinicians consider administering baricitinib instead. And so this gives us our recommendation. And so for tocilizumab, we gave a conditional recommendation for its use in adults who require supplemental oxygen, and particularly where there is evidence of systemic inflammation. Now, this wasn't a strong recommendation across the board. There are obviously some caveats. Some individuals have contraindications for tocilizumab, i.e. those with severe active infections. Also, with regards to when it should be administered, we have obviously many treatments within Australia for the use for the treatment of patients with severe COVID. So when in the line of treatment with regards to dexamethasone, remdesivir, baricitinib, sarilumab, etc., could it be administered? There was no head-to-head data comparing the different immunomodulators, so there was a paucity of evidence there. And of course, that shortage I mentioned as well. Also, the applicability to special populations. So for pregnant patients, for instance, we did downgrade the evidence further due to indirectness. So no pregnant patients or breastfeeding patients were included within these clinical trials. I believe there was actually, I actually think there was 1 or 2 in recovery, but they were in the control arm, and it was a shared control arm across the different trials. So mortality and mechanical ventilation were high certainty for adults. Now they became moderate certainty. However, tocilizumab is used in pregnant patients for other indications, so there were no safety concerns among the panel members with regards to that. And we did include further text within the additional information section to help guide treatment. For instance, here you can see we have various statements about the use of live vaccines in babies born to pregnant women who were treated with tocilizumab during their infection, etc. And there's more information. I haven't included all of it here, but yeah, there's more information within those remarks. However, that's not always the case. So, for instance, baricitinib for adults, we had evidence suggesting it's beneficial when used to treat adults with COVID-19, and so we had a conditional recommendation supporting its use in those patients. However, that did not apply to pregnant or breastfeeding women. So again, we had 0 pregnant or breastfeeding patients included within these trials. When we downgraded the evidence further due to indirectness, our mortality, which was high certainty in the adult population, went to moderate certainty, and mechanical ventilation went from moderate certainty to low certainty. And this is not used in pregnant patients within Australia. And so we're really not sure about the safety signal within pregnant patients. And so the pregnancy panel thought we need further evidence if we're going to support this. So in conclusions, so obviously GRADE is a very structured approach to analysing the evidence and developing recommendations, but as I mentioned, it is always subjective. So, 2 people looking at the exact same evidence, the exact same data could come up with slightly different interpretations of the results, or by applying different thresholds, come up with kind of different certainties and different kind of thresholds for what they would and would not suggest using in practice. This iterative approach is needed due to the nature of COVID-19. So as we're saying, we couldn't develop those refined PICOs. In particular, if you look at things like ivermectin, dutasteride, there's a whole bunch of treatments that were used to treat COVID-19 in an experimental setting where we had no idea they'd even be used before they were published, quite frankly. So we couldn't come up with a PICO question looking at the use of dutasteride to treat COVID-19 at the start because we had no idea it was going to be used. So we had to wait for the trials and then kind of apply grade, develop these PICOs, and then apply the pre-existing outcomes of interest and the critical and important kind of designations of these outcomes as we went along. But as I'm saying, as long as you have a consistent logical application of this to all of the recommendations, then you ensure that the playing field's even. So we never looked at, for instance, ivermectin and reviewed the evidence differently or applied different thresholds to that evidence than we did for convalescent plasma or tocilizumab or dexamethasone. So it was an even playing field. We applied it across all the recommendations. And let's face it, within the living guidelines, final recommendations are never truly final because next week another large trial might come out and the strength of direction might change quite quickly or the certainty behind that evidence. It was a fantastic experiment. It's a fantastic piece of work that we've put together. I'm very excited to be part of it and to continue into the future within COVID and monkeypox as well. So thank you all for listening. Again, if you have any questions, please let me know. Feel free to send me an email or hop on to our website or follow us on Twitter. Yes, thank you.
네. 히스 고마워.
Thank you very much, Mr. Heath.
이제 카메라는 잘 켰고 혹시 통역은 이제 한국어로 얘기한 다음에 순차로 들어갈 겁니다.
We will have it translated Korean first.
잘 들리나요?
Can you hear me?
Yes, I can hear you.
좋습니다. 그러면 질문을 받도록 하겠습니다.
Okay, we will be getting questions. Does anyone have any question from the attendees?
네, 사실 굉장히 사례를 들어서 클리어하게
We have gotten a lot of evidence, so it is very clear to us. It is very detailed. Thank you very much for having it presented very well. It will be a very good source for all of our researchers.
최지훈 본부장님께 말씀해 주세요.
발표하신 내용이랑 먼 질문일 수 있는데
It could be very far from your presentation.
코비드-19 리빙 가이드라인
With the COVID-19 living guideline,
연구 방법론이
we have
했는데
a lot of researchers proceeded with this.
가이드라인 하느라고
With the living guideline, all the researchers have given all their strength through this.
그래서 언제쯤 리빙 가이드라인 스탑이
When do you think the living guideline will be stopped? Or what kind of possible situation so that when it could be ended?
만약에 이제 코비드-19 리빙 가이드라인이 끝나면
And when the COVID-19 is done, and what do you think the next step will be?
Great question. So I think one of the things with the living guidelines is that obviously funding is very important. So one of the things that determines partly when a living guideline ends is when your funding ends. So if you have funding forever, then you can theoretically continue developing the living guidelines and updating the guidelines for a very long time. With COVID as well, it depends on, so when we look at living guidelines, I'm not sure if I mentioned at the start, but you need to have 3 criteria. So it needs to be a priority, there needs to be uncertainty in the evidence, and there needs to be new evidence coming out that might change the recommendation. And so when you lose some of those factors, so if COVID-19 is resolved, if COVID-19 goes away, then that's no longer a priority. And so we might decide to stop developing the living guideline for COVID because it's not important to clinicians anymore if COVID-19 is no longer a thing. And if we have strong certainty in evidence, so if we know that there are, for instance, 3 treatments that work really well, we have very strong evidence supporting those, then we might consider making it not living as well because we have the answers we need to treat COVID, for instance. But for the most part, and sorry, the third part as well, so if one of the criteria is that new evidence is coming. So we've had lots and lots of research on COVID treatments over the last 2.5 years. And we found at the start there were, we were looking at several RCTs every week that we needed to kind of incorporate into the guideline quite rapidly. And now we're seeing far less data come out. So maybe every few weeks we might see a relevant RCT that we need to include. So the actual data, the trials, the research itself is slowing down. So any of these criteria might make us stop making living guidelines for COVID-19, or it might just change it. So at the start of the process, we did updates every week, and every RCT that came out would look at it. And it was a very, very intensive process. It was a lot of work. But we've entered what we'd call sustain mode recently. So instead of looking at every study that comes out, we might just select a handful of recommendations in the guideline and make sure that they're living. But a lot of the other guidelines that were living, we might no longer have living. So we kind of prioritize which ones are the most important. But again, I think, yeah, funding is probably the biggest factor when it comes to retiring a living guideline.
네. 그러면 혹시 또 다른 질문 있어요?
Do we have any more questions? Oh, we have a question from YouTube.
리빙 가이드라인이 될 수 있는 클리니컬 퀘스천의 조건으로는 심장 감염병과 같은
We have
에비던스가 어느 정도로 생산되는지를 확인하는 등 제한적 임상 질문에 한하여 사용될 수 있는지 알고 싶습니다.
네. 네, 안 들리셨어요?
리빙 가이드라인이 될 수 있는
for it to be, what is the clinical question for the procedure for COVID-19 guideline? What can be used for the clinical guidelines?
The COVID-19 clinical guidelines.
So the question. So the question is what kind of criteria or conditions that we have to meet in order to become the clinical questions or to become the living guidelines.
So if you want to become a living guideline, so you have the three criteria. So the first one is that it needs to be a priority for decision making. And so for us, for COVID, for instance, we didn't look at things like public health or epidemiology or infection prevention and control and things like that. We focused just on the treatment and care of patients with COVID-19 because that was very important for clinicians and decision makers to have that evidence and have those recommendations for the treatment of COVID-19. The second one was that there's uncertainty in the evidence. So I think I mentioned in the talk how if you have a treatment for diabetes, for instance, like metformin, where it's been around for a long time, there's dozens and dozens of good, high-quality studies with hundreds of thousands of participants included, and they all show that metformin is the best treatment for type 2 diabetes as first-line treatment. So we're very certain that metformin is the best treatment, and so even if a trial came out that showed the opposite, the evidence wouldn't be strong enough for us to change the recommendation. So we need uncertainty in the strength and direction of the recommendation. And then the third one was, when that applies to COVID-19, obviously we had significant uncertainty at the start because we knew COVID-19 was a virus, we knew it was a disease affecting people, but there was no evidence with regards to what worked, what are the best treatments, what's the best approach. So there was a huge gap in or a huge uncertainty in what worked. And then the third one is essentially if you anticipate research being available in the near future. So some questions might be high priority and might be, the clinician might want answers for a particular question. There may be significant uncertainty in the current best approach, but then if there's no research coming, then if you're doing a living guideline, you could search, run a search every month, trying to find new data to help answer your question. And there will be no data because there's no research happening in that space. So you could waste a lot of time looking for evidence that just is never there. But with COVID, for instance, obviously we knew that there was a huge push around the world. It's the biggest research push in history to test these therapies and to find out what works in treating COVID. So COVID was fantastic from a living evidence perspective because it ticked all three of those boxes really well. It was definitely a high priority. There was significant uncertainty in what worked, and there was a huge amount of data on the horizon coming out. And so that fit the living model perfectly. But other ones, many conditions wouldn't fit the living model. But we also do living living guidelines in diabetes, which I'm involved with here in Australia, and also looking at stroke and musculoskeletal conditions like arthritis and kidney disease, etc. So a lot of these conditions do fit the living model quite well.
네, 김수영 교수님, 질문 하나만 하고 끝내도록 하겠습니다.
네, 그 호주의
We will have one more questions. Thank you very much for giving us an example in Australia. For the living guideline to be proceeded, not just the reviews, but there should be a living theme. For it to be updated continually, it should be processed continually. Especially the living panel, how can it be processed continually? It can't be that everyone will be on standby so that it could be processed. So how do you do it?
Great question. And you're right, that's one of the big problems we had, or the big issues to start with. Because normally when you develop just a traditional guideline, you might develop it over a period of 2 years, and then you finish it, you publish your guideline, and then the panel just goes their own way. They just kind of disappear and the process is finished. Whereas with us, we develop our guideline and then suddenly it's like, well, no, your job's not done as a panel. We'd like you to hang around so that we can come to you in another 3 months or 6 months or however long and give you further evidence. So one of the things we did have a panel, for instance, within COVID, we've been lucky because our panels have stayed essentially the same for 2.5 years. So we've had about 250 experts across all of our panels. We have 9 panels looking at drug treatments, pregnancy and breastfeeding patients, pediatric and adolescent patients, acute and critical care across all these panels. And occasionally somebody might leave the panel, in which case we thank them for helping us develop the recommendations, and then we find the replacement, so they'll just slot in. But for diabetes, for instance, we had 2 panels, one for therapeutics and one for technology, like insulin pumps, etc. And after we finished developing the traditional guidelines, we asked them, who wishes to remain involved throughout this process, or if you want to stay on the living panel, and most of the people wanted to stay. Some people left and we brought some additional people in. And what we're considering now as well is to have a living panel. So instead of having, say, 12 people on your guideline development group, you might have a larger pool of about 20 people that are available to participate in meetings when we have new evidence. So rather than just have the exact same group, we can send an email out to the wider group, and those that can attend the meeting or those that want to be involved at that particular point can come along and make the decisions. But it doesn't have to be the exact same group of people every time. So I think if we have a living panel, then that also makes it easier to have living guidelines.
네, 히스 감사합니다.
Thank you very much, Mr. White. We know that you're very busy. So if you would want to exit the Zoom video, you can do it freely.
네. 땡큐. 이게 채널이 달라서. 네, 이제 오래 기다리셨습니다.
You've been waiting for a long time. We have an announcement in the middle for the online attendees. If you could attend through the YouTube comments, we will give you a Starbucks coupon for the gift certificates. We were able to get the authorization for both Guides Entrance and Korean Great Network with our co-director, the Department of Urology, Professor Chung Se-hung. He will be introducing the Great Network activities. We have Professor Chung Se-hung. He will be introducing the Great Network activities.
예, 안녕하세요.
Hello, good morning.
네, 초청받게 돼서 너무
Thank you for inviting me for the NECA seminar. I didn't know how we could collaborate with the NECA network. With this, I think this seminar, we will be able to make it afterwards. Thank you very much. A lot of information was given with the grade network previously. I was invited so that the lunch we will be eating later will be digested very well, so it's going to be a very smooth presentation. All the people who know grade would know this people. It's McMaster University, Professor Gordon Guyet. He is also, thankfully, with the Philip Dam, University of Minnesota, thanks to them, this was able to happen. He was able to help with the NECA Center. Also me, I was able to meet them in America. I have a hobby of collecting pictures with important people. You could see he is also very important people on the left. He's Nurak professor. He's in name work. Do you know grade pyramid? It's not straight, it's like a maxi line, the pyramid. He's the first also there. We, the grade network, NECA Grade Center, I think national, international is for worldwide. For our center, it's for researchers and individual patients. We don't have a very big funding. We use the Naver blog for the platform. If you go to the website, you will be able to see that we are a very fresh company. Every year, we do a business night presentation and all the activities we have. If you would like to see, we could visit our homepage for more information. We have 4 members in Grade Network. For prevention, we have 2 people. For the first professor you can see is the leader. She has an event in another college. Oh, I wasn't supposed to be coming here. She was the one supposed to come here, but with her business schedule, she wasn't able to. With our network, have collaborations with the network. We not only one, we have different collaborating partners. We have connected with MOU, it's MEDIC. We have IC urology with we have Ukraine urology. When I was studying, the UST had given us a lot of help. Let me introduce you what we do. For Yonsei University, we have Chosun University as well. For Chosun University, we have evidence-based medicine. We also have university for professors and also BSA. We have 3 trainings curriculum: evidence-based medicine, systematic review methodology, evidence-based medicine, grade certainty of evidence, and also evidence-based medicine, how to conduct systematic review. We don't teach them in universities, but it's difficult for evidence-based medicine. For further training, it is hard for students. So that to understand, we only train them to understand the basis of it. We have the establishment of US Grade Network. We have Philip Dam. And we have the opening of 2018 a grade workshop. 2 people has joined us because they are a wife and husband. He is for the Children Health Center. When they attend our university, it was very popular. And after that, at 2021, with Neca Center, we were authorized. The first workshop was at Chosun University. Most of our workshop people who attend, they all do nursing or in the university for evidence. There are not much people for the approach students. For the guidelines for methodology, there's not much pool who are able to execute the guidelines. If we've heard that Neca is a very big pool for internationally and nationally, for us, we only do it beside you. It's something we do to help you for personal and private patients. At first, it was for training. And we do it for 2 days program. First, we do activities. We try to do it for on-hand activities. When we do workshops, we don't proceed them to do it. For the professor, they need evidence they thankfully had able to attend the Seoul Neca seminar joint. If they had it more, they will be able to attend even further. In addition, with our grade network, we have in our curriculum, we have Philip Dam with us for our evidence, invited international speakers for lectures as well. For the clinical certification, we teach how they were able to approach the guidelines. The people who guide Gordon approach, they do user's guidebook. We do the training with those manual books. Philip Dam has copied the user's guide first, and I've copied it with Philip Dam. We have added to the package as well. With that, I've gotten it from him and have practiced it here in the network as well. And this is the picture we took in our university. First of all, our network is Hamiak professor was the one who was taught by Gordon professor. He was the one who did the approaches for the urology as well. When we make the teachings with the Im Sang-hee professor, if the guidelines is very difficult, it won't be able to proceed with the training. Let's do something easy, step by step. Desmoprocin is a treatment for nocturia in men. It is very controversial. The information there, we've updated it in Cochrane manual. And this is the research that was done with our professors. This was not a grade. The first two was grade activities, but this last one is just an adaptive process. But this was also difficult to produce. With this approach, with Han and SJ Kim, it was really hard to process. Also for me, it was very difficult. And for the evidence researchers, it is also difficult. Right now, we are processing urology clinical practices. They do invite from universities and also for Neca. When they don't have any people on hand, we also give them supports. And with Cochrane, we keep on joining with the Cochrane Urology. And we have those people services as a contract editors. And we have Hackmaster for the Cochrane University. And the other professors is from the US grade networks. If you remember the presentation from Chen Myung, they did the research in Daehan Hansikhae. They've used the grade networking in urology. In Korea, we've approached the medical published in the HIPAC joining in Korea. This is our last slide. Afterwards, as well, if we have any good seminars like this in Neca, please invite us. If you keep on invite us, it would be very nice. We would like to come attend it every time. Thank you very much.
네, 교수님 여기 옆에 잠깐 계시면 네. 마이크 일단. 네. 그래도 이제 저희가 마지막으로
If we have any questions, if not just a question, if you have any comment, if you can provide it with us, we will be able to answer. In America, how do you connect with the networking?
알기로는 제가 갔을 때는
For me, in US network, he was able to practice it in US center, but we do not have any center. We don't have a center, it's just a networking. We don't have a center, and the reason we are a network is because we don't have enough funding. For us to establish it, we need enough people, and we should have enough investment for it to process. We have a lot of professors, but it is hard for us to get investments from universities directly. And we have nice.
몇 개 묶어볼래? 이렇게 홀거가.
Holgo also asked if we have networking together as well.
그러면 네트워크에
in network, we have researchers and university connected as well. What is the criteria for us to be connected with the network as well? When we first started, we didn't have any criteria for joining the network. We have 3, Jeonlado, Chosundae, and Yonsei together. The other networks, they are not included directly in the network, but afterwards, we were are still wondering how to invite other clinics and facilities to join our network. It is not yet gone through. We understand for the grade to be applied to a lot of people, we need to let them understand the concept of grade. Thank you very much. I'm Lee Hyung-jung from Neca. Last year and this year, we had a lot of patients regarding Corona-19. And with the patients, a lot of professors joined with this. There's a lot of approaches with Neca who gone through this, who had done practices and approaching from Neca. At first, we had a seminar for them to understand these approaches, but then we weren't able to process if they understood the concept of it. What is the hardship you have when training these concepts to other people? We have 10 panels. The people who understand grade is only 1 to 2 people. We introduce them why we have this meeting and what is the result. We let them know what is the result of this. We did 3 meetings and we had 1 question. Do we use drug or not? That was a question. But we had 3 meetings with that, and it had 2 hours per meeting. And afterwards, they were able to conclude that why they weren't supposed to do it this way. That is why we did another research and asked for a different process. Also, Heat Professor told us that this is not the only possible way. We need collaboration and consent with other people. So also with the researcher, we also need their consents. We use 2%, 3% in doing the research. And this, if it increases, this will only be processed to one side, so it won't be, the labor will be increasing as well, so it won't be connected very efficiently. We have to do something so that both of us could understand. If this is difficult, then we can do this part. If we do 3 continuous output, if 3 is very difficult, then we can do 1.5, around 50% of that. If we look at the result, it's not that different. But it could, which is why it won't affect them that largely. But it could be difficult for some people. That is why we're looking for a similar outcome.
김수영 선생님도 경험이 있으실 것 같아요. 임상이하고
네, 교수님 너무 감사합니다.
Thank you very much, Professor. Our morning session has ended. One more time, thank you very much for the on-site attendees and all our interviewers who had helped us, and all the online attendees as well. We've had prepared this very rushed, and there were things that it was very inefficient. Next year, we will prepare it even better with more time so that everyone can able to attend it on site and more better location. Thank you very much.
네, 저희 현장에 참석하신 분들께 따로 제가 이게 말씀을 드릴게요. 그래서 이제 한 번만 더 온라인으로 참석하신 분들께 말씀드리자면
For online attendees, if you have any question, we are announcing that if you join our contest in YouTube comments, then we will be able to give you a Starbucks certification.
네, 그리고 현장에 계신 분들께 잠시 말씀을 드리도록 하겠습니다. 저희 카페에 사실 이제 다 지불이 된 상태이기 때문에 여러분이 세미나에 오셨고 성함을 말씀하셔도 되고, 네, 음료를 그래서 무료로 받아가실 수 있습니다. 원하시는 거 주문 다 하시면 되고요. 점심 도시락 준비를 했고 저희가 VIP실도 빌려놨고 저 편하신 장소에서 식사를 하실 수 있고, 또 좀 간식과 뭐 이런 티 타임 할 수 있는 것도 중간에 마련이 되어 있습니다. 그래서 편안하게 이제 하시고 1시 30분에 오후 세션은 시작하도록 하겠습니다. 네, 감사합니다. 오늘 통역하신 분들 너무 고생 많으셨어요. 네, 제가 제일